following podcast is a production of Radio Felician, the voice of Felician University and the home of alternative rock done right. Download the Radio Felician app via the Apple app or Google Play stores or stream us 24/7 worldwide at radiofelician.com. Radio Felician, the Falcon. Welcome to The Felician Lantern, shining a light on everything nursing. A podcast from Felician University in New Jersey, exploring current issues in healthcare, speaking to leaders in the field, and preparing the next generation of nurses. Your hosts are Dr. Daria Waszak and Dr. Elizabeth Van Dyke, Associate Deans of the Felician University School of Nursing.
Welcome to the Felician Lantern. I'm Daria.
And I'm Liz. We are thrilled to host our guest, Leslie Wright-Brown, on today's episode, where we will delve into the important topic of diversity and inclusion in healthcare, as well as microaggressions. Leslie has been our friend for many of us here at Felician over the years, and she has served in various roles with our clinical partners. Leslie, welcome to the Felician Lantern podcast.
Thanks so much, and I'm very humbled and grateful to be here with you all today. So currently, as of November 14th, I am the Assistant Vice President for Nursing Professional Development, Innovation, and Research at Newark Beth Israel Medical Center. Prior to that, I spent the past 5 years as the Director for Diversity and Inclusion at Cooperman-Barnabas Medical Center.
So describe your former role as the Director of Diversity and Inclusion with Cooperman-Barnabas.
So it was really very interesting, I think very insightful. I was a one-woman show, so there's only one director or person in the department, but my role was varied. I think I operationalized the role from the perspective that diversity, equity, and inclusion does not belong to one person, that even though I was the director for the initiative, my whole mantra was to infiltrate DE&I into the fabric, the DNA of the organization. And that being said, I did that by working with employees. We have what a lot of industries call employee resource groups. We call them business resource groups. And basically, they were centered around, I think, traditional themes in diversity. In other words, we had a women's group. We had a Black Professionals Network, a Hispanic group, and an LGBTQ group. So they were my boots on the ground, if you will. So I worked with them to create an inclusive environment. So any initiatives, cultural theme days, for example, were really driven by those business resource groups. Outside of that, I did a lot of education. The organization had asked me really to talk a lot about racism, talk about implicit bias and microaggressions. So I found since 2017, just about every year, I was getting to around 50 to 60% of the employees, either virtually or in person, providing education. Outside of that, I also worked with the patient experience director for some complaints from patients alleging discrimination or racism. So even though she did the investigation, we noticed that there was an opportunity to share those lived experiences with our leaders. So I would take those stories, if you will, and in some cases I'd call the patients and provide a presentation during our department head meeting. And what I would do is basically walk them through, you're now going to step into the shoes of some of our underrepresented groups. And based on their experiences in healthcare, this is why they interpret things the way they do. It's helpful for us. It's information that traditionally we never get from our patients because we do service recovery. There's a complaint. We call you. We say we're going to do better. A letter gets sent. But in regards to the DE&I lens, how do we prevent, more calls or complaints or concerns from some of our patients? And lastly, I did direct education or consultation with some of the department heads when challenges with microaggressions actually came up in in many of the departments. I would provide some mentoring and coaching for the leaders whom that's when I discovered they were uncomfortable with handling some of the situations that would come up between employees. So I kind of led some of the discussions at times in the hopes that they would kind of watch what I was doing. Then we'd debrief so that they knew, I told them this is probably going to come up again. but this is how we can start to, handle it.
Does it make sense for healthcare institutions to have a dedicated role to DEI and have that person leverage and start to integrate it into the DNA?
Well, within RWJ Barnabas Health, and I think a lot of organizations, what I've seen is there is a corporate office, if you will, that's responsible for diversity, equity, and inclusion. They do want to have individuals at individual sites to actually be the lead person. I think because for us in healthcare too, it's fairly new. It's fairly new I think some of the organizations in New Jersey. When I've been on other podcasts or calls or webinars, I notice other areas of the country may have a more robust department, but still there's a department, usually more than one person, but still there's a department. So I think at this point, because we're in the country in our infancy and just starting the discussion, you've got to have, I guess, some team leads, if you will. And maybe the role of the team leads, definitely in healthcare, is to connect with employees, assist leaders, but also find allies. We have to find allies so that each one can teach one. And it's going to take time. It's going to take time, but you slowly start to connect and work with other individuals.
I like how you were describing when you talked about your role in how one of several of your approaches, but the lived experience and bringing that forward and the debriefing. And really what you're doing is you're creating a safe place for people to explore and to learn and to grow. And I see how that even in nursing and teaching nursing education, we have simulation and we debrief, and there is no right or wrong answer, but it does bring everybody else to that level and hopefully, make it more than just a one person position and to fill, because it needs to definitely spread out. And so I really appreciate that approach that you have, one of the many that you do. Absolutely.
I appreciate the fact that you bring up simulation, because that's exactly, since I had the lens from my prior job and transitioning to the assistant vice president role, we were actually talking about the competency day. We were talking about simulation, and I immediately started thinking about, okay, there's a robust simulation department here. Can we now start to incorporate maybe some of these uncomfortable or challenging situations into our incompetency day, into the simulations that the educators are already doing? So again, it's not as though it's a new phenomenon or that, suddenly we're introducing a new initiative. It's tag teaming. It's just bringing that lens to things we're already doing so that individuals, again, just become very comfortable with, oh, that makes sense. We've got the systems and the infrastructure. Why not do it?
This is the Felician Lantern, shining a light on everything nursing.
Now, I'm really excited to hear about your doctoral work. Please tell me, how is that going and what is your project?
It's going. I just got IRB approval. So that's very exciting. So it will be mixed methods research. I'm looking at stereotyping, the experiences of African Americans in the acute care, ambulatory care settings, their lived experiences with stereotyping. More importantly, I'm going to delve into their responses in these particular scenarios, their assessments, their judgments, but also how does it affect them or what is their response? So, for example, is the response, if I feel I'm being treated differently, do I not trust? And we know there's a lot of literature out there on perceived mistrust amongst underrepresented groups. And some of the end results or outcomes are very simple things, such as individuals don't fill their medication scripts. They don't go back for follow-up appointments. They don't listen to anything we tell them. So those discharge instructions get thrown in the garbage. So when we look at health disparities, another piece outside of implicit bias and other things that are being talked about in healthcare, I think there's an underexplored piece, and that is the perceptions or lived experiences of some of the patients, but gleaning from them also what is the outcome or end result of these experiences.
Yeah, being able to partner with your patient and being able to get those outcomes and then not understanding why. And I think your research is going to be paramount to moving forward. So I really applaud where you're going, and I'm very excited to see how this unfolds.
Thank you.
It's a great hurdle a great point to be at to get the IRB approval. You're ready to go.
So can you kind of outline, just kind of going back to the basics of race and racism and just kind of so we can have that foundational component, as you're building this, for your dissertation?
So it's interesting. When I started looking at possibly going back to school, I think that was 2017, there was an onslaught of literature about implicit bias, et cetera. And I noticed there was very little done in nursing. So as I started to delve, I found out that I didn't even know what the concept meant, but it really belonged to the psychology field. So I ended up having to find psychologists, social psychologists to work with my dissertation to even just start to figure out, okay, in what direction am I going to go in? And I learned from that psychologist, he's also on my dissertation committee. He said, if you ever get a chance to talk to other healthcare professionals, you need to understand these concepts. They're closely related: prejudice, discrimination, which I never really looked at them as totally different. But he said, there's subtleties. He said, but I got to tell you, the foundation to all of it is racism. So he said, that's the etiology. These other microaggressions, discrimination, prejudice are all behavioral manifestations. He said, but you have to understand what the etiology is. Therefore, then you'll understand some of the behaviors. So that stuck with me. So when we think about race or racism, race is a social construct. There's no biological basis for race. I always encourage everyone to listen to a PBS YouTube video, The Power of an Illusion Part 2, that speaks to the foundation of racism, starting with a little-known publication by Thomas Jefferson, Notes by Jefferson. So as we had the Declaration of Independence, all men are created equal, and yet we were at a time when Europeans were coming over to the United States. We had indigenous peoples here, or Indians, and also we had Africans being brought over to be enslaved. So America really had to reckon with, but how can all men be created equal but not be treated equally? So as the French and Spaniards, other folks left back in Europe were contacting Thomas Jefferson to talk about how's it going over there. Basically, he made an assessment or a judgment, and, the quote he used was, the Africans, I believe, are inherently different or inferior to the whites that are here in the body and the mind. So a lot of historians, social psychologists listened to that and believe that that was probably the first overt statement in regards to defining differences, social differences, assigning meaning to race, the comment that Thomas Jefferson made, because that comment set the foundation for, so these people are different. They're different in mind and body, different not from a positive perspective, but a negative perspective. So therefore, they are really not part of the human family in regards to life, liberty, and pursuit of happiness. So therefore, if that's the case, and as we talk now, move into the organization of racism, the social construct of racism, there is a superior group and an inferior group. So back to Jefferson, he's saying that these people are different. They're inferior to the well-represented group. So therefore, if that's the case, then when we think about organizations, when we think about allocation of resources, et cetera, well, but those people are different. So therefore, they're not quite entitled to the same things. So he set the ideology for the superiority, the inferiority. The other piece with racism is, all right, if that's the foundation, it very insidiously, because it's here, it's a comment that he made, it's a cognitive discussion that now becomes implicitly infiltrates organizations. So the government, education system, the healthcare system, religion, every organization very insidiously has adopted, because that's what's been passed down, is, but these people are different. And including the indigenous people that were here, that they're different, they're inferior. So it sets up the inferior, superior aspect. That is a core concept with racism. It infiltrates our cultural organizations or agencies. And then what happens is we start to, because we know there's something different up here in our brains, you have group characteristics that are associated with people that, again, infiltrate society very insidiously and innocently. I guess I look at Cowboys and Indians, the movies. Now I think back, on TV, and that was my only education to American Indians, is through the media. That's what was portrayed. In the absence of overt or conscious prejudice, or saying, no, I don't feel that way at all about different individuals, but because the infrastructure has now infiltrated all of our organizations, we learn these group characteristics. These group characteristics are otherwise known as stereotypes. And usually stereotypes they can be positive, but some are not so positive. And then there are attitudes that we start to adopt regarding people. Well, the attitudes have been passed down as the media, other organizations. It just becomes normalized for all of us. So if that's the foundation for many of the behaviors, like microaggressions that we're going to talk about, because that's the foundation. And because it's been normalized, what's been normalized too is we don't talk about it. The history, notes by Thomas Jefferson, I was not exposed to until I went to graduate school and sitting in a class with social workers, a class on diversity and oppression. And all of these videos, were shared with us. And I was shocked. I was really shocked. But in me, I said, oh, this is the missing link. I now understand, many things in regards to just the way the world functions. And it's no one's fault. You can't point fingers at any individual. It's the structures and the systems. That's why I understand everybody now talks about, when we're talking about dismantling racism, they talk about structures and systems. They don't talk about people, because it's not about the individual per se. It's this hundreds of year history that now is embedded in our organizations.
But we as people are the agents to change this.
Yes,
right?
Absolutely.
It doesn't seem like it's going to be easy or quick to change.
I don't think so. That really, that comment really makes me think about why not, or what are the impediments, or why is it difficult for people to have the conversation? What's the fear? I think, there is we're in the middle, I believe, since the George Floyd murder 2020, we're in the middle of a social justice, evolution at this point. Just like the 60s, it's uncomfortable. There's change. So it's uncomfortable. But I think what's different now than the social justice movements of the past is it's global. It is absolutely global. It's not just a segment of the country or even just the United States. It's global. So there's a window of opportunity, I think, to have these conversations that we've never had. I think what's been normalized is don't talk about it. For all individuals, whether you're a member of the well-represented group or any underrepresented group, you don't talk about it. And we just maintain the peace, but we always knew it existed. So what's difficult now is we're changing a whole paradigm. We're saying it's okay to talk about it, but because it hasn't been normalized, it's uncomfortable. So it's hard. It's very hard to get going. And the challenge is then creating some safe spaces to start the conversation. And where do you start? You just have to start by having a conversation.
This is the Felician Lantern, shining a light on everything nursing.
So how does that play into the microaggressions, what comes out, and especially how can we address the microaggressions? Is there more than one type of microaggression?
So the microaggressions are one of those categories of behavioral manifestations too of racism, and you'll see that with microaggressions there are hidden messages. That's what is very hurtful to people in some of these behaviors. So there are various types. What's important is not even knowing all of the types, but understanding, so what's the hidden message that is being communicated via the microaggressions and the impact on the individual. So because racism in the discussion has not been discussed, and that's the current paradigm, you can say the same thing of the behaviors. We don't talk about them. They've been normalized. So let me start with what they are. So first of all, we have to normalize them. They're part of the human experience. I know when I've done any education in the past, I start off by letting the audience know, you're not a bad person. We all will commit microaggressions. The social psychologists have documented we will never get rid of them. So it is really unrealistic to even say we're going to eliminate microaggressions. No, we're not. They're part of the human experience. We have to explain why. We have to make people self-aware and motivated enough to not execute these behaviors. So they're daily, they're brief. They happen so quickly that if you're on the receiving end, sometimes you don't even know that someone has said something or you've seen something that is insulting to you or denigrating to you. And even if you recognize that something has happened, because it's been normalized not to say anything, it's been well documented in the literature, at least more than 90% of individuals do nothing. And I think I have confirmed that even in my workshops with staff, and they'll share stories and I'll ask, so what did you do? Nothing. Nothing's going to change. Nothing's going to happen. This is my life experience. So I think it is very hard now to try to change those attitudes and behaviors. Microaggressions also come in various shapes and sizes. Some of them are verbal, some are nonverbal, like environmental cues. For example, a swastika, burning a cross. Those are symbols that you don't have to say a word, but we all know what they mean, and we know the hidden message behind them. And we know the impact on certain individuals. So some of the microaggressions don't necessarily have to be face-to-face conversations. So they can be environmental cues, is what we call them, or symbols. Some are conscious, where I deliberately decide to do something. Some of the psychologists call these very conscious, overt microaggressions micro-assaults. They are good old-fashioned isms, whether it's racism, sexism, ageism. They said, it's kind of behaviors that we're all aware of. Some are a little more unconscious and innocent, and the social psychologists will call them the micro-insults. They're insults. I think, and you know it when you see it and when you feel it, but they're little subtle digs or insults. For example, someone whom has a dialect or an accent, asking someone then, oh, you speak English very well, or acting surprised, at someone's English, and saying, as one employee shared with me, she was asked to interpret for her colleague. She spoke Spanish. She was asked to interpret for her colleague who was calling a patient. And after she got off the phone, her colleague said, wow, you don't sound like a normal Hispanic. So I asked, what did you do? And she said, I said nothing. I went there shared an office space. She went right back to typing, but she was very hurt and annoyed. And of course, her colleague had no idea that she had insulted her. But the hidden message behind that, after, we debriefed and I had a longer conversation with her, I said, so what bothered you about that comment? She said, my ethnicity is very important to me. And I've heard it on more than one occasion because I don't have, she said, a thick accent. Most individuals don't assume that I'm Hispanic or Latino, and they make the comment, you don't sound like a normal Hispanic. So, that's a perfect example of there's a hidden message that if you're on the receiving end, you know what it is. There's no guarantee, because we don't talk, that the person who made the comment even knows that they've been insulting. So, from a feedback loop communication perspective, that will continue to go on because no one is comfortable enough to maybe share. I felt a little uncomfortable when you said X, because and that leads us to, I guess, the latter half of your question is, so why don't people say anything? So I'm afraid in this day and age, in the social environment we're in, I might be afraid that you're going to label me. And as an adult learner, I definitely don't want to be perceived as one of those people whom, is not sensitive or not culturally sensitive. So there's that fear. Secondly, I don't know if you're on the receiving end, you don't know the reception that you're going to get. Is the person I'm trying to engage in conversation when I share my feelings that I feel a certain way when you make that comment? I might be afraid that for my physical safety. In the healthcare environment, we talk a lot about workplace violence. So staff have shared with me, I don't trust sometimes that there won't be physical violence. So I'm not going to say anything. And then lastly, what about the person who's observed the scenario? So in the healthcare environment, we talk to the leaders about you may be rounding or a staff member may come to you and share this was an interaction. Those individuals we now term the active bystanders. So you were a bystander, you watched, and this goes on. And it's insulting to individuals, and yet you don't do anything. How do we empower now to make you an active bystander? And what's the lingo that you should use, in intervening? So what's the, I guess, last part of this discussion? So what language do we use? There's nothing in the literature from a empirical standpoint that has definitely shown if you say this takes care of this. And I think I've learned from the psychologists is because it's human behavior. And they admit we have not tested any interventions thus far. So what have we seen in the literature, though? And it's very interesting because it mimics some of the things that we were doing in healthcare, some safety initiatives, some psychological safety initiatives. And that is just asking a clarifying question or to clarify the intent of the comment. So in the example I gave you with those two colleagues and one colleague making a comment about being a normal Hispanic. So when we role played, I said, well, what you could have said is, tell me more about, when you say normal Hispanic, can you tell me more about, what you meant or, what were you thinking in outlining or saying to me that I sound like a normal, I don't sound like a normal Hispanic. So it's clarifying the intent. We tell people don't ask why. Why makes people defensive. So the minute you say why, the back goes up, there's no opportunity for discussion. And then you got to be ready, I think, for whatever comment or feedback you're going to get. I think also what's been documented is come from a place of feelings or respect and sensitivity. And that is, I felt uncomfortable when you said, I do not sound like a normal Hispanic. Can you tell me a little bit more about that? I think most people as human beings, definitely in healthcare, I don't think anybody could argue with that approach of, I'm just sharing my feelings. And can you tell me more about, what you were thinking? Again, there's no guarantees as to the response that you're going to get. But the whole goal, we've got to start somewhere. I think the goal, too, is to start that dialogue with an individual and start by making sure they know that this is not about them or getting them. It's not a gotcha moment. It's not, ooh, I'm going to get you. It's, can we talk and have more dialogue about, this scenario that just occurred? It's almost one scenario at a time. And not every scenario will be the same.
And it's ironic that one of the reasons maybe there's no dialogue is that the person doesn't want to say the wrong thing. And then, yes. And then the cycle just continues and doesn't break.
Yes.
And I have to say, I attended the 2022 Organization of Nurse Leaders New Jersey annual conference and meeting, and you presented a beautiful presentation on microaggressions. And what I really loved is that you had a multitude of models. And what's nice about that is that the person, depending on the situation, whether they're the recipient of a comment or a bystander, can choose what they feel comfortable with. And I think that's important because that's one of those causative factors here behind this, that if you don't feel comfortable speaking up, that you're not going to, so that you're giving them tools to choose from. And with your permission, we incorporated this into a threaded discussion for our nurse practitioner students. They had an opportunity, they were prompted to share a microaggression that they experienced or observed and had a chance to apply one of the models. It was a wonderful activity. It was very well received.
Great.
And it gave, again, our students a chance to participate in that dialogue, have that dialogue, and choose one of the tools to use and go back and forth with one another about the choices and what could have been done to make that situation better. So thank you for sharing that.
Oh, you're very welcome.
You're listening to The Felician Lantern, shining a light on everything nursing.
You know, as far as you coming from a place of respect, mutual respect, and, you know, setting the stage and starting from that point is such a great way to promote and start that change. Any other thoughts, any other, you know, what else can we do to kind of help to build and promote these safe places and to promote change?
I think a couple of things. It starts with leadership. You know, leaders have to walk the walk and not just talk the talk. It also starts with empowering the employees or, you know, other individuals that it is okay. The paradigm is changing, and it is okay then to share diverse views and perspectives. As I said before, also infiltrating, I think, the diversity, equity, inclusion principles that we talked about into every aspect of an organization so that it does become normalized. It's interesting because before I left Cooperman, I was working with the human resources director. So we have a document, standards of behavior, not really a policy, kind of different from, you know, the human resource policies. But those were our guidelines for respectful and sensitive interactions in the medical center. So the two of us worked together to create standards for inclusion excellence. So again, the mantra was, I said, we've got to codify it into the structure of the organization. The standards of behavior were already part of the infrastructure. We just expanded them and created a little subset within that where there were standards for inclusion excellence. The mantra of everybody does respect and apply those standards, whether you're a leader or you're an employee. So the infrastructure was already there. It already had teeth. So we just added on to it and incorporated other principles that include microaggressions, that include if you do feel, you know, a certain way, that you certainly have the right to do X, Y, and Z, to have a conversation with someone. We're hoping, now I'm not there anymore, so the goal was, though, that as we incorporated that into our standards, that it gave some support to the leaders who felt uncomfortable with, you know, there's nothing, everyone was looking for it, but there's nothing really to address this. And I said, but you don't want to always go the human resource route because that's disciplinary. We're not talking disciplinary. We're talking creating a more diverse and inclusive environment. So we thought that maybe was the vehicle to use to just create the infrastructure and then actually see how it works, you know, in real life. So we're hoping that will be another strategy that I think in general I would encourage anyone to even look at your current infrastructures, and if there's a way to just incorporate language, look at, I'm a proponent of diversity of thought. So beyond racism, just if you're in meetings, you know, another strategy is, do we all look alike? Are they all women? Are we all the same age? I said, you know, in certain forums, incorporate that diversity of thought. I want to see different age groups, different identities across the board, whether it's gender identity, sexual orientation, age, gender, years of experience in a specialty. You want diverse views and perspectives, because when you do that, I think also the respect and sensitivity will naturally come. You don't have to dictate it, because you're going to have the diverse views, but also then create that environment for inclusion where everybody feels comfortable speaking up and sharing their thoughts and perspectives. Some of that can also be codified into the way you run a meeting. Loads of information out there on running an inclusive meeting. Making sure, for example, that if someone's kind of quiet in the background, that you intentionally call on someone. So what do you think? And 9 times out of 10, they probably have wonderful ideas, but may feel intimidated in the setting. But being very intentional, I think, with all of this, that's definitely what I'm reading is we're all good people. Definitely in healthcare, we would not go into it unless we cared about people. But from the psychology perspective, in order to move forward, we have to be intentional. If we could just rely on being good people, we wouldn't be where we are today. So at this point, we have to be intentional with some of the interventions.
And then we're going to have better decisions made and better outcomes.
Yes, absolutely. Absolutely.
And we're doing a lot of this work now as we speak with the leadership of Dr. Carlene Graham here in the School of Nursing. So
yes,
just wanted to share that. We're doing that here in the School of Nursing.
And we're also looking, from a perspective of, especially even in the lab, with our students and being able to, yes, this is a healthcare situation, but then bringing in that diversity, equity, inclusion into any healthcare situation, whether they're doing a mock code or, they're assessing an elderly patient with multiple comorbidities and treating their blood pressure, their hypertension, and I think what you said before, the health and how that health disparities, just comes. It's just, it's a direct, if you don't have trust in your provider and who's providing care for you, that prescription or that information that was provided in order to make you feel better and to have a more increased quality of life means nothing.
Absolutely.
Being intentional about it. And I really appreciate, the work, and I'm really excited to see where this goes and how we can just thread it into everything that we do. It really is more than just a one-person department, for sure.
Yes, absolutely. From the nursing perspective, I always related it back to cultural competency, which is the mainstay for us in nursing, and that we, at least in my earlier years, I remember we always talked about, now that I look back, they were stereotypes. They were group characteristics. That's the way I learned cultural competency. I expected this with this group of people, or based on diagnoses. Heart failure patients did this. This group did this. And now I look back and say, wow, now we're really trying to move away from that. Yes, that's a foundation, but to look beyond just the stereotypes, because not everybody's going to fit the same mold. And there may be things that we missed or overlooked or we assumed because this is what I learned. So therefore, that's where, that whole discussion of implicit bias and pattern mapping with our brains, that, it's there and it's programmed, it's in my memory. There's a place for it, but there's also, a place for when I am uncomfortable or I'm not sure what's happening or I don't understand this interaction, that I got to look beyond all those group characteristics that I learned.
Well, we appreciate your time so much in being our guest on our podcast. I'm looking forward to hearing more about your research and what you have going on with your new role. Thank you so much for joining us.
Yes, thank you so much. And, once you work further in your studies and your research, we'd love to have you back on again to, have a follow-up, to really find out what your findings are, to disseminate them. So thank you.
And thanks so much for having me.
This podcast has been a production of Radio Felician, the voice of the Franciscan University of New Jersey. Visit us anytime at radiofelician.com. Want to send an email? Reach out at radiostation@felician.edu. Radio Felician, the Falcon.